Whatever you practice, you're gonna have bombarded with all the back pain. So you have to deal it if even you don't like it. So middle cluneal nerve. So the middle, I mean, usually the cluneal nerve is not the one like they teach a lot in medical school or even in the fellowship or residency. Just recently, I was interested in those nerves. So middle cluneal nerves, they are branches from the posterior ramus of the sacral nerves. They're coming from L5, S1, 2, 3, and 4, mainly S2. So there are many branches of nerves, but the most important one of them is lateral to the S2. And kind of many branches, but they come together mainly lateral to the S2. But they are all around. They are not just like a one nerve that you can see it. It's not like a brachial plexus. It's just like a nerve, and adding also the variability of the patients. So as you see in the image in the right side, those are the sacral dorsal foramen, S1, S2, S3, just lateral to those foramen are all those branches supplying all the posterior ligaments of the sacroiliac joint and the posterior aspect of the sacroiliac joints. So patients have sacroiliac pain, status post fusion. You did already the SI fusion, or he had fusion before our like fusion, lower lumbar fusion, and have sacroiliac dysfunction. Sacroiliac pain simply. But you can ask me a question. I mean, any patient with sacroiliac pain purely, you're gonna implant for them middle cluneal nerve. I mean, I don't have a best answer for this, but if the sacroiliac pain or more of a mechanical issue, peripheral nerve stimulation may not be the best solution for the mechanical issue. Will still going on. You need more of a stabilization. But if it is kind of a sacroiliac pain, that's a neuropathic and more like widespread, you may think the sacroiliac, the middle cluneal nerve will be of a value for you. So the placement, I found the middle corneal very difficult. I think that it's easy. I just touch the sacrum, put it there. I mean, simply you want to put the lead lateral to the posterior sacral foramen and medial to the sacroiliac joints. I think it's safe. There is no really vascular structure there. It just some the sacrotubular ligaments above the posterior dorsal sacrum. As you are not going inside the foramen or too much like lateral or deep in the abdomen, you are safe. So it's safe procedure, but it's very difficult.
Because of the curvature.
Exactly. The curvature is up, and you're going from down, and you want to have the lead like this. So it is not an easy procedure. You do simplicity, still do simplicity SI, RFA. I think you still do them here. So it's the same, but the opposite. Instead of going from down up, you go from up down. That's why it's more difficult. I found it one of the most difficult nerves to really put the lead in a correct location for especially a lot of patients like big, they have already fusion, there's already like metal in your way, so you have to make a lot of changes.
Even with curving the needle, you don't get can get over that curvature. So if you curve the needle like the simplicity, that will also not happen.
This is what we exactly do. I mean, try to curve the needle a lot and just to get over a curvature, but it is difficult. It's easy to say, I do this. It's common in real patients, huge, all of them have fusion, curvature, and try to get it in, and it's painful. And sometimes even bloody a little bit. The posterior act of the especially with the needle, is traumatic and bloody. You need sedation. You need to be off the anticoagulation. It's middle corneal. I found it not that easy target. But ideally, we will go from up down, cranial to caudal. You start around L4ish, depends on how big the patient is. You touch the sacral L, and then move it lateral to the sacral foramen, medial to the sacroiliac joint, The challenging part is to keep it over the sacrum as much as possible. You don't have to be like really on top. If you are a little bit superficial, it's fine. And actually, maybe this is better because if you are immediately over the bone, you stimulate, like 180 or 200. If you go a little bit farther from the bone, you may stimulate 360 and get all of those branches. The most important S2. So this looks okay. Maybe ideally it's a little bit up because this is maybe missing some of the S2. But usually also another tip, like with any BNS, usually the migration happen. Not really migration, but the lead will move. And usually it will move backwards. So if you are a little bit farther your target, usually it's fine. Let's say I need the lead to be one contact more caudal, more cranial. But so it will move a little bit back, one contact. So even like suprascapular, just if you half a centimeter farther than you want, because it will come. And also if you have because you put it there, you're comfortable with the position, the tines are there, but I want to pull back in the lead just tiny bit, because I want to time the tines to to anchor, to engage exactly the tissues. So I would pull back just half a millimeter just to make them to anchor to the tissues. So that's why when you insert it, maybe I will insert it tiny farther. And your entry point around L4, but then where are you going to do your second incision? So your second incision, again, you can customize it as you want. If you do bilateral, you can cross them. So one leads down at the middle cluneal, other middle cluneal, and then you cross them across. So if you cross them, you can have a bend, so do a suture here. But when you cross them, the advantage of crossing, the patient will have use one wearable to stimulate both. And also you can have only two incisions, because you can have one incision to the right side to put the lead, and one incision in the left side to put the lead. And then you will cross the lead from the right incision to the left incision and opposite. So you can have only two incisions. Sometimes it's not visible. The patient have like metal like this. You have scar in the middle and scar, and you cross them across the scar, like and maybe fracture difficult. So you're gonna do your first incision here to put the lead. Your second incision is up. So you patient have two incision for the right, two incision for the left. But he will use two wearable, one for the right and one for the left. But maybe this is easier. Your lead is straight, and you don't cross the midline, but you can have 4 incisions and 2 devices wearable.
Slick.
But again, patient, this is different. Superior cornea, very common. And if you look for it, and if you really think it's existing, because some would think it's not existing. There's nothing called superior corneal neuron. But if you think it is there, and if you think it's real, you're gonna find it a lot. So anatomically, those are like branches from the dorsal rim. So they are when you do medial nerve branch blocks, you block the cluneal. When you do RFA of the medial nerve branches, you block the cluneal. So the cluneal are branches from the dorsal rims, from T12 all the way to L5. And then they come together, they go through the erectospinal muscle, especially the lateral aspect of the erectospinal muscle, and then go posterior to the quadratus lumborum muscle. Like regional guys will, when you scan for the quadratus lumborum muscle and erectospiny, and you look to the images of latissimus dorsi, erectospiny, and the quadratus lumborum, if you look, there's like a small triangle in the image, lateral to the lateral erectospiny, like iliocostalis part of the the iliocostalis part of the erector spine muscle, lateral to it, if you see like a tissue plane that with the posterior thoracodorsal fascia. In this tissue plane, all those nerves like exit, go through the muscle, and then go over the iliac crest. So even when you inject them, we can inject them with a fluoroscopy, get the iliac crest, middle third of the iliac crest, or junction between the medial middle third of the iliac crest, touch the iliac crest, inject. But if you go with ultrasound above it, you can inject them there above. So as you see, there are many branches. Again, there are not like a one, there are multiple branches going over the iliac crest. Either it is a medial and middle and lateral cluneal nerves. Some of them, sometimes all of them are entrapped. Some of them are only the medial, with the Megan syndrome, or this is the medial one, but some of them are all. It depends on the pathology, the patient exam. But ideally, the first branch is around like 6-7 centimeters from the midline. So if you have a midline, it's around like 6-7 centimeters from the midline, and around like 3-4 centimeters lateral to the posterior superior infected. So this is kind of your initial points that you're gonna start here. Sometimes those patients, like who is those patients? Sometimes patients have compression fracture. They have superior cluneal neuralgia. Sometimes a trauma, excessive like twisting movement. There's post fusion, lumbar, like post lumbar laminectomy. A lot of them have superior cluneal neuralgia. It's like a more of a neuropathic pain. You touch the iliac crest, they jump over you. And sometimes they have like a pseudosciatica. So it's not only like a back pain, iliac crest pain, because as you see here, there are branches from T12 up to L3-4. The majority of them branches from L3, L4. So sometimes they present it to you for a radicular pain in L3, L4 distribution. But you touch the cluneal, you touch the iliac crest, like they jump on you, even if they have radicular pain, even below knee. You think that's below knee, it's no way cluneal. So it can be below knee. Majority is above the knee, the referred pain, but sometimes they have referred pain below the knee, and it's still like cluneal neuralgia. A lot of your spinal cord stimulator patients that they're still not happy with their back pain. It's still like they use the stimulator, the radiculopathy better, but it's still back pain. And they're still using the stimulator, but their back is like, to touch them, a lot of spinal cord stimulator patients have cluneal neuralgia. You see the course of the nerve, it is like a wavy curvature. Well, I mean, not curvature, it's like a wavy course. This to allow movement, because it goes through all those muscles. So the patient like flexion, extension, to allow this, like, you know, the course, like flexibility of the course. If this is interrupted, it's like kind of entrapped. The nerves are entrapped. If you are not sure, because it's not the clear diagnosis sometimes, do diagnostic block, low volume. Don't give tons of volume. You will lose your maximum 5 ml or so to see the response. And do trial. Trial also will confirm this is real. So we go from medial to lateral, and it's not like a difficult question. It's not like the middle cluneal. Unless there is a lot of hardware, you can also have difficulty. But usually it's straightforward. So we go from medial to lateral, around like a lower L4, L5. Just touch the iliac crest around like 5 centimeters from the midline, or 3-4 centimeters from the posterior iliac spine. And then once you touch the iliac crest, you keep moving it over the iliac crest. A lot of times, because the iliac crest is not sagittal like this, it's curved anteriorly. So once you touch the iliac crest, you keep advancing anterior a little bit, deeper and anterior, because if you touch the iliac crest and you just move, you will miss it. So if you miss it, you end up your lead in the subcutaneous tissue, and the nerves are over the iliac crest. So you miss the nerve. And in EP, it looked for you good. You do EP view, the leads are in perfect position. But actually, it is in the subcutaneous tissue in a perfect position. So doing lateral is difficult, so you do contralateral. So contralateral, like 30, 40, depends on the patients. You see the iliac crest in the image down there? So you will having the lead over the iliac crest. So having this contralateral oblique useful to be sure that the lead is over the iliac crest, or I use ultrasound. Okay, because you can see it's very superficial. You can see it there. And then
the last time we tried this, we were having a hard time getting it with the contralateral oblique. It kept going like more anterior, and I think that was the reason. Because remember we were doing that one time together. Yeah. I mean, on the AP it looks perfect.
Yeah,
You look at the contralateral oblique, and it was like overshooting.
Right.
What is that?
So,
I don't remember it.
That was interesting. That guy responded really well
Yeah.
to a block, but he didn't really respond to the stimulation.
Oh, was that like really
Yeah.
kind of weird guy?
yeah.
Yeah.
I'm not surprised.
Yeah.
Victory.
That was like probably patient selection more than technique.
So the trial didn't really help.
It's weird.
He started well with the trial, but then at the end of the trial he said like 10-20% relief.
Oh yeah, I think you told me. He's like,
There's,
oh, it was great. Pain's all gone. Better. 10%.
Yeah, initially, yeah.
Yeah.
And then he got relief from his groin pain as well from his superior Cluneal.
That's another interesting.
So.
no, we had a vision for the brachial plexus.
Yeah.
We get a relief 100% immediately. Immediately.
Yesterday.
Yeah.
From
It's a brachial plexus. Immediately he got from his hip pain gun
Hip pain.
Hip.
and table. Okay.
You know, I already feel it warming coming over me, Adam. I'm like, you're welcome.
the power of placebo, you know.
And it is positive. I will take it.
He's, he's so convinced that, Mom, you have a spinal cord, you're getting that out and you're getting this in.
Oh my god.
She's like, okay. She made an appointment with him. What?
The humans are very weird.
Weird subjects.
Really.
Yeah.
Yeah. I mean, it is.
But
Yeah,
he's
I'm
like-
an anesthesiologist, and like I do chronic pain now 5 years.